Hello, and welcome to today's master class in periprosthetic joint infection. I'm Dr. Ken Yurch at the University of Pittsburgh. I'm a professor in the Department of Orthopedic Surgery, and we have a great faculty lineup today with Dr. Plate, also from the University of Pittsburgh, Dr. Piuzzi from Cleveland Clinic, and Dr. Omutala from Stanford, truly experts in the field discussing new approaches and technology for the management of implant infection and contamination in these complex orthopedic procedures. First, Dr. Plate is going to be talking today about the current state of periprosthetic joint infection. Dr. Plate.
Thank you so much for having me. I'm Dr. Johannes Plate. I'm an orthopedic surgeon at the University of Pittsburgh, and I'm excited to talk about the current state of periprosthetic joint infection today. Here are my disclosures and legal disclaimer for this talk. And we'll begin with a quote from Sir John Charnley from the 1960s and 70s, where he recognized really early on that joint sepsis or infection is going to be the major hurdle in the future of joint arthroplasty. And if you look at the current incidences from 2019 to 2025, multiple studies have shown still 0.5 to 2% of a combined incidence of PJI, which despite all of the advances that we've had over recent years in patient pre-optimization, antibiotic prophylaxis, surgical techniques, decreased surgical time, still 0.5 to 2% of incidence of PJI, which is really truly high if you think of the number of total joint replacements that we're doing in this country. And if you look at the reasons for revision for total knee replacement, this is a recent study. Infection has become the #1 reason for revision. When you look at total hip replacement, infection is making its way up, currently #3, but over the next few years, probably higher than #3 reasons for revision for total hip replacement. And looking from 1996 to 2020, you see the same trend. PJI is going up while aseptic loosening is going down. So while our polyethylenes have gotten better, we have less aseptic loosening, less catastrophic wear. So PJI is slowly but surely creeping to be the #1 reason for revision total hip and total knee replacement. And this is going to continue to rise. So a study from Andy Schwartz and Tom Bradbury, the projections are not great. If you look at PJI, it will continue to increase as the reason for total hip and total knee revisions. So there is a big problem, and we need to find some ways to fix this. Because if you look at the impact of PJI, the costs are significantly higher when you compare it to primary total joint replacements, 3 to 6 times more costs with an annual 1.8 billion in the US alone. And it's become one of the most expensive complications in medicine. And it also has a significant impact on patients. When you look at a study here of 5-year survivorship after PJI, it is actually higher than prostate cancer, melanoma, or breast cancer. About 25% of patients will die in the first 5 years after PJI, which is something we have to keep in mind, and therefore the treatment or the protection from PJI is so important. And there's different types of PJIs. An acute or early post-operative PJI is really within the first 4 to 6 weeks of the index arthroplasty. And most likely, this is from bacteria that was inoculated at the time of surgery. There's a chronic or delayed PJI, which is usually beyond those 6 to 8 weeks after surgeries or a symptom onset of about 3 to 4 weeks. But it's more of a low-grade infection that may also be related to the primary surgery. And then you have late hematogenous PJI, which usually is a PJI that occurs once the implant had been fixed for years, and then you get bacteremia or a distant infection that seeds the prosthesis. But we'll be mostly talking about acute and chronic PJI. The late hematogenous PJI, like I said, is mostly a secondary infection from urinary tract infection, dental abscess, or things like that, with organisms such as Staph aureus, Streptococcus, gram-negative bacilli. When you look at the chronic or delayed PJI, which usually happens around 6 to 8 weeks after implantation of an implant or around 3 to 4 weeks after the onset of symptoms, it's usually caused by more of a mature biofilm formation on the implant surface. And that can lead to an indolent but sometimes progressive inflammation and implant loosening. And that's mostly due to low-grade, slow-growing organisms. And some patients may or may not have systemic symptoms. And here you see the organisms, coax negative staph, Cutibacterium acnes, so slow-growing organisms. And we think that in some of these infections, the initial bacterial inoculation actually happened at the time of surgery or during an early transient bacteremia after surgery. And that then leads to chronic inflammation, can lead to osteolysis, and potentially some loosening of the implants. For an acute PJI that occurs really after the index arthroplasty within those first 4 to 6 weeks, that is more of an acute type setting with acute pain, erythema, swelling. That usually happens to Staph aureus, beta hemolytic strep, enterococcus, things like that. And we think that is truly the direct inoculation of bacteria during the surgery or during the early postoperative wound healing, where you can have bacteria that adhere to the implant surfaces at the time of surgery and they begin forming biofilm. And that biofilm then matures and can lead to that early postoperative PJI. And the incidence of acute PJI is actually relatively high. If we look at some international studies, the acute PJI incidence ranges from 47 to 70%. So around 54% of all PJI are actually acute PJI. Chronic PJI only around 30 to 55%. And so a large number of PJIs actually occurs within the first 3 months after surgery. So when we think of those first 3 months, it's really the perioperative window that has the highest risk of PJI, but also is the best target for interventions. And we have already done a lot during that perioperative window to help the incidence of PJI. So if you look preoperatively, we have optimized the patients. We make sure that the hemoglobin A1C is low, the BMI is optimized, no smoking, their nutritional status is fine. We're using all these wipes to clean the skin. We shave the skin with those electronic shavers and not dry. During the operation, we prep the skin. We make sure that there's no contamination in the air with laminar airflow. We change our gloves. We make sure the instruments are all sterile and we handle the implants properly. And post-op, good wound care, make sure that there's no drainage. If there is drainage, we go back to the operating room. We have different types of dressings, some with silver, some have other options. We make sure that patients get good post-op nutrition. But even besides that, there is the risk of intraoperative inoculation. And that is from airborne contamination, from just personnel being in the room and shedding skin. The instruments can get contaminated. You can have bacteria on the patient's skin flora itself, and you can get the implant contaminated during the time of surgery. And when you look at all these options, we have gotten so much better with laminar airflow that most of the now current ORs are equipped with laminar airflow, where you have airflow that comes down from the ceiling and it pushes away the bacteria. However, even in the cleanest, ultra clean rooms, you still have 10 colonies of bacteria floating around the air. In a conventional OR, still with laminar airflow, but with surgical teams, with door openings, with traffic going in and out the rooms, you can have 100 to 300 colonies of bacteria floating around in the operating room that can get into the wound, it can get onto instruments, it can get on the implant, and it can directly inoculate your surgery that you thought was sterile. Personnel can shed little skin squames, about 10 to 100 or a million skin squames per hour. And those skin squames potentially carry 1 to 10 viable bacteria that then can infect the instruments, can infect the wound and your implants. And as your number of staff in the room increases, right, residents, students, but also scrub techs, anybody in the room, reps, they open the door, go in and out and get the implants, you can increase the particle count around tenfold in the operating room, despite all those things that you were trying. Also, you can get glove perforations, and the perforation rate is around 12% in primary total hip and total knee replacement. And when you have glove perforations, skin bacteria can get into the wound, can get on the implant. So we introduced a joint bundle at Wake Forest while I was there, which included limiting door openings, no personnel changes during primary total hip or total knee replacements. And we cut little holes into the cuff of the gowns to keep the contamination of your own skin underneath the cuff, and that seemed to help us with our PJI incidents. But anything in the room can really get contaminated. The light handles, 50% of manipulated light handles are positive for Staph epi and Staph aureus during the case. Cautery tips can get contaminated. The suction devices, after a certain period of time, can get contaminated. 18% of suction tips, even in the cleanest ORs, get contaminated no matter what. Your surgical hood that a lot of us are wearing, it's not sterile. Air can escape through the neck and through the back that has your skin cells on it. It can get on the back table, it can get on the implants. If you touch the front of the hood, you can get bacteria on your gloves that way. And just by putting on the helmet, you can get contamination on the helmet itself. So even in the cleanest ORs, there is contamination, about 16.5% of cases, and it gets worse with revision total joint replacements, where in septic revisions, 80% of things are contaminated, and aseptic revisions, 13% of things in the OR just get contaminated. And the patient's skin flora is a problem itself too. Human skin has around 10 to 100 million bacteria per square centimeter, with Staph epi, acne, Staph aureus, things like that. And even with the best skin prep with chlorhexidine or povidone iodine prep, you clean the skin surface. However, about 1,000 to 10,000 bacteria remain because they live in the deep hair follicles or sebaceous glands that retain these bacteria. And even within 2 hours, these bacteria will come back on the skin surface. And Ioban doesn't help. Nothing really helps. Bacteria will come back onto the skin surface. They can get onto your instruments and they can infect the wound. So even the best skin prep will not protect you all the way. And you can get implant surface contamination as well. You can get biofilm on titanium or polyethylene, even with a single bacterial colony, which can then cause PJI. And it's really the moment of packaging breach. When you open up that sterile implant, it is critical not to have it get contaminated right away. Just the air can contaminate it, but even your gloves can get contamination on them and then put it onto the implant surface. So when you handle an implant, try to not touch the ingrowth surface or on-growth surface. Change your gloves before you put the implant on. Try not to touch the implant on-growth surface onto the skin of the patient while you're putting the implant in, because you can just get a single bacterial colony on there, which can then cause PJI. So really, with all that being said, any bacteria in the wound or on the implant can cause PJI. And as we just heard, nothing in the operating room is really sterile, right? Because you want to prevent this, you want to prevent biofilm formation. So as you look at the early or acute infection, you have planktonic bacteria that float around in the wound. They can get onto the implant, they can accumulate, and they can then form mature biofilm. So it's really that early phase, the first few hours after surgery, where you have your biggest or greatest window of opportunity. Because once the biofilm matures and it releases bacteria, you really have not a lot of options left. Because biofilm is antiseptic tolerant. So you can treat it with cefazolin, you can treat it with povidone iodine, you can treat it with chlorhexidine, you can throw hydrogen peroxide in there. Most likely this will work against planktonic bacteria, but it will not work against bacteria in biofilm. You can also try to irrigate it, but it only removes about 90% of biofilm from PMMA or metal, and it will not remove everything, and some biofilm will remain, and you will continue to have a high risk of PJI. And biofilm becomes resistant to antibiotics. It has a physical barrier. That EPS matrix really limits the diffusion of antibiotics. It prevents MIC to actually reach those sessile bacteria on top of the implant. You have persister cells within the biofilm that really don't take up any bacteria, so you can't kill them. The biofilm alters the microenvironment, so it changes the oxygen barrier. It is more acidic. There are nutrient gradients that reduce the potency of antibiotics and really escapes the immune system. You have genetic exchange and quorum sensing. There are efflux pumps that pump antibiotics away from the biofilm. that will, lead to persistence. And it will actually evade the phagocytosis, and your host immune system will not reach the bacteria inside the biofilm. So once you have mature biofilms, there are all these mechanisms that will not allow the biofilm to be killed. So what is the best option? This is from the 1860s from Joseph Lister. And he said, well, the best prevention is cleanliness in the operating room. But again, nothing in the operating room is really clean. Despite all the technological advances and all the changes that we have made, no surgery is truly sterile. Contamination will happen in any surgery. And it seems like that the first hours after surgery are really most critical and your best window of opportunity. And one option to protect the implant is Nanocept, which is an antibacterial implant coating. It's actually a 70 to 75 nanometer covalently bond molecule that has a quaternary ammonium that creates a positive charge that will actually disrupt the bacterial cell wall on contact. So you have metal, you have this covalently bond molecule on it, and it will kill any bacteria that come in contact with the implant. And there are studies that have shown that in an in vitro model using a spray system of Staph aureus and Staph epi on cobalt chrome implants, there is a significant reduction of Staph aureus and Staph epi with this molecule to almost close to 100%. And so these findings would support that Nanocept can prevent bacterial contamination on the surface of the implant prior to implantation. So thank you very much, and I'm happy to answer any questions.
Dr. Plate, thank you very much. Those were some very interesting thoughts. Next, instead of doing questions at the end of each talk, we're going to save questions online. We're going to condense them at the end. So our next speaker is going to be Dr. Amunatalla from Stanford, talking about improving treatment effectiveness in periprosthetic joint infection. Dr. Amunatalla.
Ken, thank you so much for the kind introduction. I am super excited to be here and talk about improving treatment effectiveness in periprosthetic joint infection. And I'm really fortunate to be here with my other colleagues, Johannes and Nico, who are going to cover the other aspects of this topic. It's great to be here. Personally, I spent my career focused on periprosthetic joint infection. It's one of the most, I think, exciting and universal topics in orthopedic surgery. And this talk is actually not really going to be about treatment effectiveness, but maybe where we fall down and how we could think about things differently in order to improve them. So I have numerous personal and professional disclosures. None are particularly relevant to this other than I consult with oncos. And I think we need new levers inside of infection. As far as I'm concerned, one of the major issues in periprosthetic joint infection is the bacterial life cycle. We've spent multiple decades focused on the planktonic phase of bacteria. And we have multiple diagnostic criteria and tools focused here, but not very many tools focused on the biofilm portion of infection. And the tools that we have in biofilm treatment really center on debridement, removal of implants, and potentially increasing antibiotic concentration. And finally, we may have some new levers inside of this space. And so I think it's this point of view, the point of view that really recruiting neutrophils or causing inflammation through surgery and increasing antibiotics are the only things that we can really use as surgeons that are the things we can optimize. But at the same time, they're the things that fundamentally hold us back. This is the culprit. The culprit is biofilm. And I want to use this slide to reinforce that biofilm is its own organism. And that organism centers around the biofilm resident bacteria that live inside of that extracellular polymorphic substance. So that is the issue. They start just binding to an implant, but they quickly form these bacterial communities, and you'll see that it looks like a beehive. It basically looks like cells that are forming their own encasement and their own place to live. And the reality of that encasement is it makes the bacteria less susceptible to antibiotics, They can actually share resistance because imagine all that biofilm is actually made from dead bacteria, so it has DNA that they can uptake. It can slow the metabolism because there aren't a lot of nutrients around and actually can harbor persistent bacteria, which we'll spend some time talking about. And it can also dysregulate the immune system. So I mean that by planktonic bacteria and biofilm resident bacteria don't stimulate the immune system the same. Let's think about that for a second. Each of us is kind of sitting here with 40 trillion bacteria. You only have 30 trillion cells. So really your bacteria are doing a lot of the work. And I'm going to tell you, you're not attacking the 40 trillion cells you have. It's that biofilm and the interaction of those bacteria with your immune system that actually lets you live in tolerance or in homeostasis, let's say, with those bacteria. And that's part of the problem. Let's get to the treatments. The treatment is debridement and implant retention. The reality is this is best for early infections. The hard part is I'm not sure a lot of hematogenous spread infections exist based on our data. And if the infections are truly coming from the host themselves, as a spine surgery data, they may all be there in a chronic state. And so we see DARE have some really odd results. In some patient cohorts, it can be as high as 90% at 2 years. In other cohorts, it can be as dismal as 50% at 2 years. This is largely probably centers around the patients that are included, the types of hosts, and I will tell you, debridement bias. So none of our studies really focus on this. And we focused on time and follow-up as a reason why our treatment interventions are hard to analyze. But imagine I'm doing a DARE. I think there's another surgery I could do later if I needed it. And I'm not going to remove all the implants or debride the back of the knee effectively. And so, of course, that debridement bias, that inability to attack the problem with full force, and I told you again, antibiotics and debridement, full force debridement leads to highly variable results. And I would expect those results to be variable between 50 and 90%. That's the reality of the situation. Also, you got to realize the data here are not as good as you wait more time. The 5-year data of DARE suggests the failure rate could be as high as 40 to 60%. So everything in time with DARE fails more as persisters emerge from those implants. So nothing, I highlighted this, nothing ruins good data like long-term follow-up. So look at this study, 6 months, 70% survival. Excellent. As we move out over time, the survival drops. And you can view that as glass half full. Hey, I did a DARE and 40% of the patients did fine at 5 years, or 50% of the patients did fine, right? So you can view that glass full. We helped some people. But I could also view that as glass half empty. Glass half empty is perhaps we should be moving more implants than we DARE. And then improving DARE is optimizing a suboptimal procedure because we can't debride the knee effectively. We cannot use the levers available to us. I'll highlight that. This is our data from Stanford. The 94% at the top is if we got a hold of that patient first. If we got a hold of that patient after a DARE, a 1-stage, a 2-stage, someone else did something to try and treat an infection, our cure rate at 2 years basically declined to 80%. And you say, well, okay, that's good. That's not a huge decline, 14%. The answer is it's absolutely terrible. The number needed to harm is 7. I can challenge you to find anything in orthopedic surgery or cardiac surgery that has a number needed to treat better than that. Meaning, for every patient treated in the community, for 7 patients treated in the community, 1 patient got a new infection that we could have prevented if this was treated as a specialized surgery center. For me, what this argues is also debridement bias. If I'm the person that's going to see this patient back, I'm going to hack out a lot more tissue and hack out a lot more implants than someone else who's going to see this and just pass it on the line to me. So our embracing of DARE hasn't really helped us very much in my mind. And again, I'm not trying to disparage DARE. What I'm trying to say is DARE does something different. It gets implants out of people's offices. But DARE doesn't necessarily drive more cure. It just drives, again, more reoperation at a later date, at a later time. We also found that infections circulate around to different surgeons. So you might not even know how good your dares really do. The gold standard people have largely touted as two-stage reimplantation. And to define this, it's basically a first stage where the implants come out, we debride things thoroughly, we then place an antibiotic spacer, and then either dynamic or static, we can talk about that a little bit, and then they're reimplanted when deemed uninfected. That has an 80% survival, 80 to 95% survival rate at 2 years. But realize again, long-term survival suggests that this may also decline to 60% or so over 5 years. And so that we may not be doing as well as we think, meaning persistent bacteria may remain on that spacer, as Ken showed, or persistent bacteria remain in the soft tissues and the environment. So that's why we get declining results over time. Again, same bug. There's no real difference in treating patients with oral or intravenous antibiotics in the phase of the first stage. So a really great study from the New England Journal of Medicine largely showed this, and a lot of us are moving away from intravenous antibiotics. It's expensive, it has a high level of side effects, and oral antibiotics are the same. But I think this also indicts antibiotics post-op, meaning, are they really doing anything? Are they treating the persistent tolerant bacterial population? And studies have come to show that oral antibiotics can be reduced even shorter than 6 weeks to 2 weeks, etc. And it might be that debridement is a more dominant lever than antibiotics. And so I would encourage you to reduce the antibiotic burden to your patients. And it's unclear to me the role that antibiotics are playing in the post-op eradication interval. I told you all spacers work. All static spacers, all dynamic spacers, particularly in the knee, work. Whether you use a cement puck or a fusion or a metal and plastic spacer, a prefab spacer, custom spacer, I can't tell you that any of these are different in terms of their eradication rate over time. You know, what I can say is one of these spacers could be retained, and I can talk to you a little bit about how that spacer might help. And some of these spacers can increase our patient's motion to make a subsequent surgery a little bit easier. But ultimately, I would tell you they all leave behind the same persistent bacteria on that spacer, and maybe the high-dose antibiotic spacer is just trying to suppress the amount of bacteria that live on it. Then there is no difference in the eradication rate across these types. In the hip, also no difference in articulating and non-articulating spacers, whether we use a non-articulating or an articulating hemi or an articulating total hip, no difference in the eradication rate. And you can see from the picture in the middle, there is a difference in the complication rate. So more dislocations when we place articulating hips. Nice paper in 2009 indicating the increased dislocation rate with functional hip spacers. But lots of us do functional spacers. It's a way to get out of the surgery in a 1.5 stage because you can retain spacers. On the topic of retained spacers, I have spent, and a lot of other surgeons have spent some time working on metal and plastic spacers that are durable. We don't plan the second surgery, we leave them in. So what is the fate of those spacers? So the fate of those spacers is that 2 years, 80% of those spacers are in. And that over longer intervals, 5 to 10 years, the 70% of those spacers are in. But what I want you to notice is how they fail. 10% have failed by infection. That's the same as the 2-stage reimplantation data. Additionally, 20% have loosened. That's the opportunity of the 1 stage. I also want you to note here, graphed here is the 1.5 stage data in red. But in blue is the final reimplantation data of 2-stage. So what I would tell you is 2-stage is not necessarily the gold standard anymore. 2-stage has the same failure rate as 1.5 stage, it just takes 2 surgeries to get it. And so with all comers treated with mobile metal and plastic durable spacers, we can do even better than a 2-stage. Let's talk about that 1 stage. The 1 stage seems great. We do a 1-stage surgery trying to eradicate infection, but realize those persister cells are going to remain behind. And we see that in the outcomes. 60% to 97% eradication rate at 2 years. So why is it like that? Well, one, debridement bias. So if I think I'm going to do a 1-stage as opposed to a 2-stage, and I don't have another shot, I'm going to debride it really, really hard. Second thing is these are a highly selected patient population. So patients can't have a sign extract, can't be culture negative, can't have multiple organisms. And there's particular protocols in order to get this done. And so by cherry picking the patients, maybe it can be better. The 1.5 stage data didn't do that. And again, we're going to have to figure out if you fail a 1 stage, they're not all the same. If you fail a 2 stage, you get a new spacer. If you fail a 1.5 stage, you get a new spacer. You fail a 1 stage, you get a new DARE and suppression, or you get an amputation or a fusion. Is that a good result? So probably 10%, again, it's not going to be any different than the 1.5 stage or the 2 stage data, are going to get reinfected. Maybe you can modulate or delay that with protocols and selected patients and debridement, but probably not, because the persister cells are the ones that are left behind that we have no levers to treat. And is it worth a 10% amputation rate or re-washout rate to block 20% of loosening when our patients don't survive that long and they don't need that much function? It's hard for me to argue that the 1 stage is the gold standard, but it'll probably emerge. And realize if the pros get 97%, when we apply this to everyone else, just like we looked at our data with DAREs and 1 stages and referring them to another center, there's no way it's going to be that good. So I think the trough of disillusionment will come for 1 stage. It's something everyone's going to try. But if you're not getting great results from a 1.5 stage, I wouldn't attempt this at all. Otherwise, you're going to place your patients at risk for catastrophic failure. And this is that catastrophic failure. One of the treatments for infection is fusion or amputation or disarticulation at the hip. These are unbelievably morbid procedures. I like the one on the right for in certain patient populations, a pseudo fusion nail, which basically fuse the leg without a durable fusion and then fill the leg with antibiotic cement. I think that could be a good option. But again, that's left to be proven. None of these options are good. And the more we predispose our patients to these salvage and amputation related surgeries, that's not the best we do. So I'm going to leave you with some final comments here that I'm not sure with all of this treatment diversity, whether we do it in 1 stage, 1.5 stages, or 2 stages, or we wash it out and keep the implants. Let's call that 0 stages. We do any difference. We hover between 80 and 90% at 2 years, and we don't really have a great window, like I showed you, past those 2 years. And we have a ton of debate regarding what kind of spacer, what kind of dose, what type of antibiotics, what route, how do we give them, what the post-op antibiotics do, how long do we do them. What that tells us is we need new levers. We're arguing and quibbling over the smallest things that make a smallest difference, that make us feel like we mastered infection. But I'll tell you, none of us have really mastered infection. And the only way to not get an infection is to prevent an infection. We saw that with preoperative antibiotics, which is why I'm excited about new preventative tools in this space and whether they can block those persister cells in your tissue from landing on that implant. So I leave you with this, and you decide who you are. This is literally from The Art of War. And everyone probably listening to this talk is for sure a warrior looking to fight infection. But if you know your enemy and yourself, you need not fear the result of 100 battles. We're not there. We're losing many, many battles because we don't know ourselves or the bacteria or our patient. If you know yourself, like many of us think we do, but not the enemy, I guarantee you no one spent some time thinking about what those bacteria are doing. For every victory gained, you will also suffer a defeat. I live here. Many of us live there. But if you know neither the enemy nor yourself, you will succumb in every battle. If you're not treating infection and you're daring everything to send it to someone else's office, that is not helping anyone, patient, yourself, or us. We need to think about this harder. We need new weapons, and I'm glad they're coming to bear. This is my lab. I spent my entire career thinking about this. I'm glad that everyone's here thinking about this and willing to try to think about things differently. Ken, I really appreciate your time, and I look forward to the debate.
Derek, thank you very much. I agree. The orthopedic infection truly is a battle, and we are waging a war. Next, we have Dr. Piuzzi from the Cleveland Clinic talking about new technologies and approaches for periprosthetic joint infection. Dr. Piuzzi.
Thank you, Ken. That was a kind introduction, and it's a tall order to follow Dr. Plate and Amaratula, but I'm going to give it my best try. So I'll be sharing with you new technologies and approaches for PGI treatment. These are my disclosures. And it was well mentioned, right? PGI is a major problem, right? If you look at the mortality rate at 5 years, or that we have even at 1 year with PGI, it's very large. This places a big burden on patients and the caregivers. And when you look at it in the big scheme of things, the mortality rate of PGI is as close as many of the common cancers that we treat. Therefore, this highlights kind of like the background that was well presented by Dr. Place, like how important and relevant this is, and the need that we have for new technologies and new ways of treating these patients. So when we look at the current research focus and the challenge that we're seeing in the field, we can divide them in the prevention, diagnostic, and treatment. But the truth is that if we look at it like and scrutinize what has happened, why has the needle not moved farther? And I do have to probably acknowledge the elephant in the room in my perspective, that we still have an incomplete understanding of the mechanisms and the host responses to infections, which hinders our truly effective development of technology that can actually help in the prevention, diagnostic, and treatment, because oftentimes we're kind of going blinded to the underlying mechanisms that we're facing. So one of those, and one of the main challenges, is our understanding of PGI and immunity, right, and the immune host. Many of the things that we've actually based our decision making on relies on work that has been done on osteomyelitis or work that has been done in vitro. So this is important just to acknowledge that we need to advance in this area so that we can actually make a better dent in what's happening. So when we look at the approaches to PGI, there are a lot of them, and a lot of things that have been mentioned that we're currently doing. But the question, well, what are the current challenges and how do we look forward? Of course, you can look at it in the prevention, diagnostic, and treatment. For a matter of time, I will focus on prevention and treatment for this presentation. On the prevention, if you look at any of us as an orthopedic surgeon or joint and hip replacement, this is my practice from last year. The thing that we need to be able to identify which are those patients that are going to get a complication. And ideally, we want to do it before the surgery happens, understanding which patient is at high risk. And I think this is, although this is very basic, this is at the core of what prevention actually means. So how does this work? So I believe that we need to kind of move towards a personalized approach in that shared decision making, that we can tailor specific treatments for individual patients. This is an example of the care pathways that we have at the Cleveland Clinic, and any institution now has their own, and everybody knows kind of like what's the pathway that we do to bring a patient safely to the OR. The challenge that all this ends up happening in a surgeon's or a provider's head, right, with experience. Well, how do we make this institutionalized and a process so that we have no misses, or we can actually move the field forward? Because if you go through it, there's just a lot that goes into this, and we need to use probably technology in the optimization of patients and this pathway. Some of the things we've done is we actually put technology, we use AI machine learning in trying to build models so that we can actually inform this decision making and this path, trying to provide better care for patients. This is how it looks. You input the patient data on the left, and then you can get a prediction of what's the patient's predicted improvement at 1 year in their pain, function, quality of life, and also what's the risk of postoperative complications relative to the average patient of that same age, gender, and comorbidity profile. More importantly, how is this system fed? Well, we standardize the data and the variables that go into it. So we have a standardized risk factor assessment. And as you can see, this is taken out of EPIC, so you can know exactly what are the risk factors you're dealing with. And then many of these get put into the models, and you get the predictions, and you have the breakdown of what are the drivers of that, so you can actually work on the ones that are modifiable versus the ones that are not modifiable that you need to mitigate with different processes. The challenge comes that when we continue to look into the prevention, for example, in the irrigation solutions that we use in the OR, the data is not amazing, just to say the least. And that's because probably if you look at it, it's very hard to come up with high quality data to be able to drive the optimal irrigation solution. And although there are a lot of them available, the data to choose one over the other one is not that strong. So making decision making in this prevention arena more challenging than in other areas. When we go into the treatment, lot has been discussed about the 1-stage versus 2-stage versus 1.5 stage. Across new technologies that are coming, we have this BTX7 with a clear protocol, so which basically it's a rapid 2-stage where you do an explant, you place a spacer, you irrigate multiple cycles of antibiotics during a week, and then you do a reimplantation a week later. How does this look? This is a case where you can see a patient had a chronic PGI with a sinus tract on the right hip. The explant is performed, the spacer is placed. You can see the tubing that goes right into the spacer, the sponges that go there, then how the sponges are placed, how the back is sealed. And after multiple cycles of vancomycin and tobramycin during a week, a patient this is the interim spacer, how it looks. And then a week later, the patient is reimplanted and then continues with the 6 weeks of IV antibiotics and then plus minus suppression. And data is coming soon to be published on the 1-year combined results of the randomized control trial on this technology with promising data to support another avenue to treating infection that is not just the 1 or the 1.5 or the 2, is adding also continuous washes and vacuum assisted. If we look at what new strategies and new modalities are there are a lot of things that are actually coming and that we'll have available for use in a near future and also like today. Well, I would divide them into 4 main categories: implant coating, biologics, electrochemical methods, and small molecules. Let's start with the first one, implant coating. So Nanocept is one of those where you have a non-eluting antibacterial surface coating that is applied to orthopedic implants. This creates a cationic nanoscale contact kill surface that disrupts the bacterial cell membranes and that in preclinical in vitro studies have shown to have an extremely high kill of organisms that we frequently encounter as potential contaminants in the OR. So why is this relevant? This is relevant because in April 2024, this technology got a de novo authorization, which is a great accomplishment because we don't have treatments that are on label and pass the entire FDA process. So when you look at this coating that is non-eluting and that stays with the implant and can potentially decrease this contamination and the seating of the implant, this opens a new umbrella and you can make the bridges there of the potential implications this might have in our field and in the care of the patients that we have. Other things that are around, well, silver coating. These are coatings that have slow release of silver ions, and they serve a role, right? They've been there for some time, and there's data to support the use of these with some claims of reduction of PGI after complex reconstructions, and overall, these are other options that are available. More recently, there is also the use of iodine coating with controlled release of iodines in implants. This was recently got breakthrough designation in the US, had previously been approved in Japan, and we're waiting for clinical data to see the value that these coatings might have in care. On the biologics, there are many things available, and they're a little bit earlier, but we have some clinical trials going on. One of those with antimicrobial peptides that it's important to understand, like, well, first, what do they do? So the peptides, they have multiple claim mechanism of action in membrane disruption, biofilm disruption, they have intracellular target, immunomodulation. They have a broad spectrum of activity. One of those is an engineered peptide PLG206, of which it's been designed and it's been proven that it's safe in systemic applications in the first phase 1 trial with no reported adverse events relative to its application. And then if you look at it, it also has a broad spectrum of coverage across PGI, bacteria that are commonly done, and we finished the phase 1b trial where the safety was confirmed, and now we're moving forward to a phase 2 to try to determine its efficacy clinically, and just things to consider that we might have available for treatment in the near future. Electrochemical methods are there, and they've been around for some time as well. If we go into them, there's decent amount of in vitro, in vivo data, and they kind of consistently show that you can get a 2 to 3 or up to a 5 or 7-fold decrease on bacteria. But it raises the question well, is the decrease on the amount of bacteria or microorganisms that you have sufficient, or do you need to go for that eradication? Because if you're leaving bacteria behind, and sometimes some of the treatments require long period of treatment, well, how feasible is it, and how effective will this be if translated into potential clinical practice? One of the additional treatments out there that this is something we've developed with our group, with Dr. Higuera and Annabelle Visperas, in collaboration with Case Western, is this phototherm D-amino acid gel that is an anti-biofilm treatment. Basically, you have the D-amino acid with gold nanoparticles that we activate with a laser. This is all from our preliminary work, and we actually published this last year, where we did in a deer model with our rabbit model. We shown that we have very robust biofilm eradication with this treatment, although there are still shortcomings in regards to potential applicability, because it's a long treatment with the laser, and the treatment took about 2 hours, and we're working on decreasing the timing, optimizing the process, changing the configuration of the amino acid gel to be able to give that jump to potential clinical application. And just to wrap it up, I do think that when you look at all these new treatments, it's interesting that the majority of the knowledge we've gained has been through animal models, and our understanding of that immune host for the new treatment strategies is still quite superficial in many aspects of it, and we need to have a more in-depth analysis and understanding of the biomarkers and the gene expression across these conditions, so that we can actually come up with better treatments. When we look at it, I think an omics approach with a multi-level analytics, where we're introducing proteomics, transcriptomics, microbiology, and immunology all together into the current treatment armamentarium that we have, will hopefully yield a better understanding and better treatment, so that we can actually change the needle and hopefully change the field once and for all. In the meanwhile, this is what I see forthcoming, and I'll be looking forward to our discussion and taking it from there. Thank you so much.
Nico, thank you very much. That was a really interesting talk with some promising technologies to help solve this very difficult problem. As we discussed, we were going to open the floor to some questions. If you have any thoughts that you'd like to ask our faculty members, please type them into the chat box now. We've actually already had 1 or 2 come in. One here that I saw, it's pretty straightforward, so I'm going to do moderator's prerogative, and I'll just pick it off myself. Do you think protecting the implant from contamination makes sense? Is an ounce of protection really worth a pound of cure? Well, the Sir John Charnley, when he started doing hip replacements, noted that the incidence of infection was about 1 to 2%. When I'm talking to my patients today, I still use those same numbers. And so, if you want to keep a problem from happening, the best way to do it is to keep it from happening. I see some other questions coming in. This next one is, I think, for Dr. Amunatala. What are some of the biggest misconceptions in treating periprosthetic joint infections? Derek?
I think that's a great question about what the misconceptions are. I think the misconception here is that the things that are in front of us antibiotics, debridement, irrigant environment are strong, equally strong levers. Perhaps biofilm embedded persistent bacteria are more strong or more strong than anything else, and we don't have a lot of levers to treat them. I think this comes out in a different way. I think surgeons take getting a PJI really personally, and you may be doomed from the get-go because a lot of this has to do with the host and the bacteria that are on the patient's skin. And I think the fact that surgeons, the misconception that this is something that I gave the patient or I did this or my protocol could change, I think that creates two big problems. One, people don't want to take on PJI because they feel bad. They feel like this is a problem that someone gave the patient. And when in reality, it's something the patient got from themselves. The other thing that happens here is we make a lot of random protocol changes because we're just worried that we're not changing all the things. And there's a lot of treatment anxiety. A lot of those are not as strong as we believe. And I think that you should stick with your guns and think hard about what you're going to change. Not if you got a recurrence, change your irrigant to another irrigant, thinking in vain that it's going to make a huge difference, or change the item X around and 1 more gram of this or powdered that's going to make a difference. That we're all struggling against this together, and there aren't a ton of obvious, easy changes. And if there were, we'd hand them to you.
I completely agree. Here is a question that came in a little bit ago that I thought was really good. Is there any one method or technology coming up that you feel is more promising than the others? Nico, this was really kind of in your domain. What are your thoughts?
Thank you, Ken. That's a challenging question, right? And especially because it's going to go on record. But I don't know if there's one that would give us, based on where we are, the most. This is what I would tell you. I think it's the combination. I'm looking on the treatment side. I'm looking I think very auspiciously into some of the peptide work that we have, in some of the new technologies that we have to disrupt biofilm and treat that biofilm not only on the implant but on the soft tissues. I'm very excited about that. I'm excited about some of the treatment that we have with new approaches, like what the OCL technology that we are all part of on the trial and we've worked on. I think that gives something new to it. But I'm also very optimistic about the tools that we have now to reimplant patients with coatings, where if anything were to be left behind or a reinfection were to happen, that patient will have a lower chance of getting contamination and potentially getting an infection. So when I tie all these together, I think we're now at a moment where finally we're getting new tools, right? And not advocating one or the other. I'm just thinking of the patient perspective at each of the different areas, either in diagnostic, treatment, or in the prevention, both for the recurrence or before. We have new things coming, and I think that's the message. So I will not commit to one. I do love that we have things getting through the FDA, things becoming on label, and us having tools that hopefully all together in combination will yield a better outcome than what we've seen in the past decade.
Thank you very much. There's another question that just came in. With the current main treatment options, DARE, 1 stage, 1.5 stage, and 2 stage, what are we doing wrong? What can we be doing better? Derek, this fell into a lot of the topics in your talk. What are your thoughts?
So of the available treatment options, I think there's kind of probably 3 things to think about here. One, we probably over-apply DARE. It's really convenient, and a lot of us don't want to bite the bullet to remove implants, and it really calls for the formation of an infection center. We should be treating these like tumors and removing these to the definitive surgeon faster. That clearly makes a difference for patients because think about debridement bias. If I debride a lot of implants, I'm going to get better at debriding implants. The only orthopedic law is volume begets outcomes. So the fact that we all spread this volume out is not helping us. DARE is, I don't think, our friend. I'm not saying it doesn't have a role. It has its role in certain patients. Megaprostheses also, it has a role. But we probably liberally apply DARE too much and impede progress. I think one stage is actually another one. I do think there's a dark side to one stage. Every adopted technology, there's a negative to it. And I think we're not going to talk about the negative until we start seeing it being presented to our academic centers when people start doing it. And I think if you're not successful at a 1.5 stage, I'm not sure you should progress to a one stage. So I think there needs to be a proving ground for when you take things on and when you're ready for something like that. Because if my 1.5 stage have a 30% infection rate, that's going to translate right to my one stage. That's my debridement. That's the result of my debridement, my antibiotics, my team, my protocol, my environment. And I think the last thing to really think about in terms of deploying kind of those resources is that we oftentimes think the spacer matters. So like deploy whatever spacer, just don't have it stick out of the patient's extensor mechanism. And for me, again, if you send the patient to me, I'm going to deploy a durable mobile spacer because I can get a one-stage result with none of the one-stage risk. But I can't tell you one's better than another now. What you need to do is be willing to rip out more implants and put in more spacers because that gets our patients out of this chronic biofilm phase that forms within 3 days, like super rapidly within 3 days, avoids the use of suppression, etc., and puts us in this middle ground. So I would tell you, if you're gonna be more liberal about ripping out implants, I think that's actually a good thing. If they're primary implants, I don't know if DARE for me has a tremendous role unless somebody is super sick.
Well, that's about all the time we have for today. I'd like to thank our faculty for their time. I'd like to thank our audience for attending. If you have any other questions, please reach out and let us know. And we'll wrap this up for today. Thank you very much.